The sixth biggest mistake that I see paramedics and EMTs make in their handoff report is not obtaining a good baseline for the patient. This is something that's super vital to get on scene because often these are patients that are confused and they can't provide a good history. And it's something that can only be obtained on scene from family or friends or whoever is what is the patient's baseline mental status? Are they normally confused and this isn't a change for them at all? Or is this a rapid change? They're normally functioning individual and now all of a sudden they're confused and can't care for themselves. That's super important for us because if I obtain a normal workup in the ER, I can't send somebody home that's actively confused. They might need a brain MRI, they might need a further workup in the hospital that we can't provide in the ER, and I can't send that patient home. But if they're normally confused and they have a history of dementia and they're at their baseline level of mentation, I can send that patient home. And a lot of times I can't get that information from the patient, so it's vital that you get that on scene. A lot of times we'll end up having to look up phone numbers and call the family to get that information. So it's super helpful for us if you can get that information on scene. And kind of along that same line is last known normal, which is not the same as symptom onset, right? So we get a lot of confused elderly patients that their last known normal is when they went to bed last night. That's the last time they felt normal and they woke up with these symptoms. Their last known normal is not when they woke up with the symptoms, it's what time they went to bed feeling normal. And that's something I see get confused a lot. And I got yelled at a bunch when I was a paramedic for not getting a good last known normal. But that's super key information that a lot of times we can't get after the fact. And so it's crucial that you get that information for us on scene. Even if you're getting a quick handoff from the fire crew and they're loading up the patient, and if that question is still in your mind, please go back in the house, go back in the facility and get that information because it's super, super important for our disposition of the patient. And of course, that information is critical for, stroke alert timing. If the patient qualifies for TPA, that information is absolutely invaluable when we're kind of considering those implications. The seventh big mistake I see paramedics and EMTs make in their handoff reports is the physical exam. It frequently gets left out, and I want to know what your physical exam showed. I want to know where their abdomen hurt when you pressed on them. And that's something I probably was not good at as a paramedic. Maybe I was a bad paramedic, but you need to be pushing on all four quadrants of their abdomen. And it really matters to me which part hurts or if it just hurts all over because I start forming that list of differentials in my mind. If they're having right upper quadrant pain, I start to worry about their gallbladder. If it's right lower, I start to worry about their appendix. If it's all over, I worry about a small bowel obstruction. So when you do your physical exam, I really want to know your pertinent findings. Now, if it was unremarkable, you could say the physical exam was unremarkable. But if you have exam findings, I really want to know the pertinent findings. If you get called on a shortness of breath patient, I really want to know what their lung sounds were, especially before you intervene and gave them breathing treatments or started them on CPAP. I really want to know what they sounded like initially because now their lung sounds have probably changed based on your intervention. So that's a very pertinent thing to bring up in your handoff report. On that same line is, did the patient walk? I always ask the crews this because if the patient normally can walk and they couldn't walk to your cot or you had to carry them all the way out of their house, I'm probably not going to be able to send this patient home. I'm not going to fix whatever their problem is, I'm not going to be able to fix it probably rapidly enough in the ER that they're going to now magically be able to ambulate around without any problems. Now, sometimes we can, but a lot of times if you had to carry the patient all the way out of their house, they're not going to be leaving the hospital. There's not going to be something that's that quick to fix that we can send them home to walk up 4 stories to their, upper floor apartment. We're probably going to need to keep them in a hospital until they get their ability to walk back. So if the patient walked to your stretcher or you had to carry them out, that's very pertinent information for us when we start to think about our disposition. The eighth biggest mistake I see paramedics and EMTs make in their handoff report is assuming that we got a phone call ahead of time about the patient. Now, we likely did. Likely, if I go pull the patient up on the computer system, there's a big transfer note in there that tells me everything I need to know. But I haven't seen that when you arrive. The patient's not registered, so I know basically nothing about this patient. So operate under that assumption. And that's just kind of something that has to do with the way our system works. It would make sense that you would assume we got a phone call, but whatever provider's seeing you when you first come in, we probably haven't read that transfer note. We probably don't know what's going on with them. And in those patients, it's okay to lead with their diagnosis. So if you're bringing someone, especially from one of our outlying facilities, you can lead with the diagnosis. Like, this patient has appendicitis. They're here to see a general surgeon, right? We don't have surgery at many of our outlying facilities. So you can lead with the diagnosis. If you lead with the whole backstory of this patient had abdominal pain and they went into the freestanding and they got a CAT scan, that kind of just confuses it. I want to hear what the diagnosis is or what they're chiefly concerned about, right? If it's a dizzy patient coming in from the outlying facility, they probably need a brain MRI. They're worried about stroke or something like that. So you can lead with the chief concern or the chief diagnosis, appendicitis or concern for stroke. And that immediately tells me, okay, I know what the patient's here for. And then you can give me their whole backstory and how long they've been having symptoms. And I can listen with the understanding of, okay, this is what we're working them up for. And then I can pay a lot more attention if I know why they were sent here and you lead with that information. On those patients, we really don't need a super long report either, because I'm going to have to go look in the computer and I'm going to read the whole chart of the previous provider. I'm going to be reading the transfer note. I'm going to be looking through all their lab work and imaging that was done prior to arrival. And so you don't have to do a super long story about that, because most of our work is going to be going and seeing what was done and seeing what we need to do and what specialists we need to consult. That's the bulk of the work on those patients, not really obtaining a thorough history. That process has already kind of been completed. But what I do need to hear on those patients is if there were any changes en route. Have their vitals drastically changed? Are they in more significant pain? Are they having new neurosymptoms? Those are things that I really do need to hear, because I don't know what happened between that sending facility and our facility. So definitely include that information. Number 9, the ninth biggest mistake that I see paramedics and EMTs make is passing along their patient bias to the provider. We all see a lot of patients that don't have real pathology going on, right? The majority of the calls you run, the majority of the patients I see in the ER are not actively dying and are safe to go home, right? But when you color the provider's assessment of the patient, you're not being a good patient advocate. So if you think that the patient is intoxicated, that's fine for that to be one of your differentials. But if you don't really have any solid information that they've been drinking, if you don't smell alcohol on them, you didn't find evidence of it in their house, they didn't admit to alcohol, we kind of need to make sure this isn't a stroke. We have a lot of intoxicated patients that come in, but we need to really make sure that that is a likely differential. We should probably check an alcohol level. And if it's normal, we need to broaden our differential and make sure this patient's not having a stroke or a brain bleed or something crazy like that. And we do see those patients sometimes. And our alcoholic patients that come in are super high risk for brain bleeds. Those guys fall a lot more often. And, these things do get missed because of patient bias. Confirmation bias is a big problem. So when you give your handoff report, try not to pass off any of those biases to the provider. Even if we try not to pick up on that bias, you are kind of unknowingly coloring our view of that patient. So this all goes into the number 10 biggest mistake that I see paramedics and EMTs make, and that is writing off patients. And like I said before, we all see a lot of patients that are not dying, they're able to go home safely, and that's the majority of our patients we see, whether it's on the ambulance or in the ER. And so it's easy to have that tendency to write people off, right? Most of our patients are not dying. But in the ER, we have a different perspective. It's very much in the paramedic culture to kind of assume a patient's full of BS until proven otherwise. In the ER, I've had to really make a big shift from paramedicine, and that's to kind of assume the patient is dying until we prove otherwise. Part of that's because we have a very litigious society, and if I'm going to send someone home, I really need to have some objective data to justify why I don't think they're dying of whatever their complaint is. As a paramedic, you see a lot of very, very sick patients. You're seeing patients that are actively dying. You're seeing cardiac arrest patients. You're very, very used to seeing these critical patients. And so it's easy to write off the ones that are stable vital signs and complaining of chest pain. But I would encourage you not to be super hasty about making that decision, because sometimes they do have real problems. I get a lot of patients in the ER that the crew might have written off as anxiety, and that patient actually has a pulmonary embolism. Or somebody that's written off as, oh, they're just complaining of abdominal pain. They've complained of this a bunch of times. It's really not that bad. And they have appendicitis. Sometimes these subtle complaints have real pathology behind them, and it's easy to write them off. We all struggle with that. We all see a ton of patients, but I would just encourage you to not bring that bias with you to the hospital and not pass it on to the provider, because we do it to our patients to make sure they're getting thorough workups for their complaint. Your goal should be to allow the provider, the PA, the nurse practitioner, the doctor to have an objective viewpoint of the patient when they go in to do an assessment. When we bring in patients from intake to the back, I'm going in with a pretty fresh, objective outlook. I'm reading their complaint, I'm going in with a fresh set of eyes and being objective. But if you're kind of passing along that bias to the provider, you're coloring that ability to be objective. And we might miss things as a result, and we could have poor patient outcomes if we're, bringing our bias with us into the patient room. As an ER provider, we really start with, the patient is sick until proven otherwise. If a patient is having chest pain, having shortness of breath, I assume that this is something dangerous until I've objectively proven that that's not the case. And sometimes we can prove that with a good physical exam. Sometimes we can prove that by looking at their very stable vital signs. It doesn't always necessarily mean a whole bunch of imaging and lab work. Sometimes we can objectively rule out the bad stuff with a good physical exam. The other part of that is if you let these patients frustrate you that have non-emergent complaints or that you think don't have something legitimate going on, you will get burned out a lot quicker. The majority of our patients we see are not people that are dying, but that doesn't mean that they don't need our help. That doesn't mean that they don't need reassurance and that they don't need a workup or they don't need to come to the ER. You will burn out quicker if you just get frustrated by these people rather than kind of seeing it as part of the job. When I was a paramedic, you would run a critical patient and then you would run a whole day of non-critical patients, and you would let those patients frustrate you, like, why are you calling me for your twisted ankle, or why are you calling me for your chest pain when you're a 21-year-old? But we owe it to these patients to give them a thorough workup, and if they want to come to the ER, you bring them to the ER. It's part of the job is seeing patients that don't know what an emergency is, proving to them that it's not an emergency, and still providing good patient care while educating them. Educating them is a big part of the job. We see a lot of twisted ankles and stubbed toes in the ER, but sometimes those are fractures. And so we still owe it to those patients to work them up and take good care of them. Just because you wouldn't go to the ER with a stubbed toe doesn't mean that someone else doesn't realize that's an emergency. And that's what a lot of our job is educating patients about emergent conditions and proving objectively that it's not something that's emergent. And just so that I say it once, all the opinions in this podcast and in this YouTube channel are mine alone. They don't reflect anyone that I work for or have worked for. They're solely my opinions and don't reflect anybody else. If you guys like this or got some value from it, please like, comment, or share. Please tell me what information you guys would like to get from my perspective, what things would help you guys, what things about what we do as providers and APPs, what stuff frustrates you guys, what stuff can we do to help you guys when we interact with you, what things about our job are you curious about? I really want to know like what education topics you guys think would be beneficial, and I want to know what you guys want to know about my job, because I do want to encourage those of you that have even an inkling that you want to be a PA or an advanced practice provider. I want to encourage you guys to go that route. I really enjoy being an ERPA. I think it's a super fun job. It's, keeps me very energetic. There's always something to do. I really enjoy my job. And so I want to encourage those of you that want to do that to go that path. So I want to find out what information you guys want to know about being an ERPA that I can kind of provide you with. Or maybe you decide not to go that route, but that's okay too. What information can I give you guys to help you make that decision? Anyway, if you guys took the time to watch this, thank you so much. I'm super new at this, so I appreciate any feedback you guys have for me. I hope you got some value out of this. And yeah, give me some feedback. Thanks. All right. Hi, guys. My name's Aaron. I don't know. Should I be dressed as a paramedic, you think? I mean, I kept the clothes for a reason. I don't know. Maybe I'll try as a PA. All right, we'll try this. This is PA Aaron. I don't know. It still feels kind of weird. I mean, I'm at home. I'm not seeing patients right now. Why do I need to be wearing scrubs? I don't know. It still feels weird.